All right, hello everyone. Thank you for joining us for this month's Teach Educational Round. Here with us today we have Rosa and Shelley, who will be presenting on implementing a suicide risk assessment protocol for non-clinical research staff working within a smoking cessation program. Before I hand it off to our presenters, I'm just going to go over a few housekeeping slides. If you're interested in receiving a letter of completion for today's Teach Educational Round, please make sure that you've registered for this webinar and completed the pre-learning assessment. As well, you have signed in to view this webinar using your first and last name so we can track your participation. And finally, you have completed the post-learning assessment, which will be emailed to you by the end of tomorrow, and you will have 1 week to complete that. Please note that a copy of today's presentation slides will be sent along with the recording this afternoon as well. This webinar is being live tweeted on Twitter, and you can follow us at @PSQuitSmoking and use the hashtag #TeachWebinar to post or read questions. Here's a little bit more information on our first presenter, Rosa. Rosa has been at CAMH since 2000 and has extensive experience in addictions and mental health. Rosa plays a key role in developing a strategy for education research and programming, and she is also the lead in the PACE project, training curriculum that address health behavior risk factors such as diet, physical activities, stress tolerance, sleep and alcohol use, all to help clients improve their quit outcomes for tobacco. She also plays a key role in other tobacco projects, including the STOP program, and has contributed to tobacco control initiatives, including CAMH's Smoke-Free Policy Development and Implementation, Rainbow Tobacco Intervention Project, and the Provincial Cessation Task Group. You can read more about Rosa's work here. Here's some information on our second presenter, Shelley. Shelley started her role at CAMH in 2017, initially working in the TEACH project as an education associate and then a community health and education specialist. She is now a project coordinator within the Nicotine Dependence Service, managing various research projects and knowledge translation initiatives focused on smoking cessation interventions. She played a key role in the STOP program's Mood Management Initiative, where she provided knowledge broker services to Ontario family health teams and helped develop a suicide risk assessment protocol for non-clinical staff members. She has also contributed to the development of several practitioner and patient-facing resources and offers ongoing support with the CAMH COVID-19 online discussions forum. Here's a list of their disclosures, and here's some more information on our disclosures. Please note that the content of TEACH educational rounds are centered on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussions, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. Please feel welcome to use the chat feature during today's webinar to provide any feedback or post any questions. To use the chat feature, you can click on the speech bubble icon in the control panel, and please ensure that you select everyone to make sure that the panelists and hosts can read your questions. As a note for this presentation, I will be collecting questions that come up during the presentation, and we'll have a question and answer period at the end. With that, I'll leave it to our presenters to take it away. Thank you, everyone, and please enjoy the webinar.
Thanks, Sophie, and thanks so much, everyone, for attending this afternoon's webinar. So as Sophie mentioned, today's webinar is going to be on how we developed and implemented a suicide risk assessment protocol for our non-clinical research staff. Just going over the learning objectives for today. So first, we're just going to describe the association between smoking cessation and suicidal ideation. Next, we'll explain the need for implementing protocols for suicide risk assessment within smoking cessation programming. And finally, we'll discuss some of the steps that were involved in developing and implementing a suicide risk assessment protocol for non-clinical research staff as part of the STOP program. And so I just wanted to take a moment first to sort of acknowledge the impact of suicide in Canada. So on average, each day, approximately 11 people will die by suicide, leading to more than 4,000 deaths by suicide each year. And in about 90% of those cases, the individual did have some previous diagnosis of a psychiatric illness. But for every person lost to suicide, there are also many others who've experienced thoughts of suicide, suicide attempt, and hospitalization from self-inflicted injury. And then as well, many others who are significantly impacted by the loss of someone who has died by suicide. And so while there's no one single risk factor for suicide, there are several factors that might increase an individual's risk. So these can range from biological, psychological, environmental, or social. So for instance, when we look at sex and gender, we see that suicide rates are about 3 times higher in men than women. As well, life circumstances and major life changes such as social isolation, financial stress, and the death of a loved one can also increase one's risk of suicide. And 2 of the major contributing factors to suicide include substance abuse, such as alcohol dependence, as well as mood disorders, including major depressive disorder. So when we look at the literature, we see that there is an association between depression and suicide. Compared to the general population, individuals with depression are about twice as likely to smoke. And someone with depression might smoke to sort of alleviate those feelings of low mood and stress. And this is because nicotine can actually cause short-term elevation in mood because of the release of dopamine on the brain. However, since nicotine is a stimulant, it can actually exacerbate those feelings of anxiety and low mood, and in turn, increase these levels of stress and depressive symptoms. So these individuals are also more likely to experience greater nicotine dependence, are more likely to relapse, and also experience greater negative mood changes when making a quit attempt. As well, when we look at the literature, we also see that there's an association between smoking and suicide. And this relationship appears to be a dose-response relationship. So those who smoke more actually present a higher risk of suicide. As well, within active and daily smokers, there's also an increased risk of suicidal behaviors such as suicidal ideation and suicide attempts. However, as I mentioned, although the literature does confirm this relationship, it's unclear what exactly the cause is. So whether it's something specific about smoking which affects brain functioning, or whether it's that smoking is linked to other behaviors such as alcohol dependence, depression, and anxiety, which again then increase that risk of suicide. As mentioned, because these risk factors tend to overlap, smoking might be conceptualized as a way to self-medicate in order to relieve those symptoms of depression and anxiety, and potentially then reduce the risk of suicidal ideation. So when an individual is making a quit attempt, this might contribute to an increased risk of suicide because now one of their main coping mechanisms is being removed. So because of this, screening for suicidal ideation as part of smoking cessation treatment is an important aspect of suicide prevention efforts. But again, while that link between suicidal ideation and smoking cessation is challenging to understand because these risk factors, again, tend to overlap, what we do know is that quitting smoking is associated with reduced depression, anxiety, stress, and overall improved mood and quality of life. So that being said, there's strong evidence that shows that when we integrate a psychosocial mood management component into standard smoking cessation treatment, it can actually increase long-term cessation rates in smokers with both current and past depression when compared to standard treatment alone. So based on that research, in 2018, as some of you might remember, the STOP program launched its mood management initiative. And this was essentially an initiative to support our healthcare providers who were participating in STOP with integrating treatment for depression as part of their smoking cessation program. So as part of this initiative, we implemented a number of different tools and resources and pathways within the STOP portal to sort of help practitioners screen their patients for depression as part of their enrollment in STOP. And then for those who were presenting depressive symptoms, we encouraged them to provide their patients with a brief 2 to 5 minute mood management intervention. And then in those with more severe depression, encourage them to, again, refer their clients to more specialized care, so a social worker or a psychiatrist or something like that. And so this sort of brings us to our second point. So what is the need for implementing these protocols for suicide risk assessments within smoking cessation programming? So as mentioned, I'm gonna go a little bit. Yeah, so as mentioned, as part of the mood management initiative, individuals enrolling in the STOP program are screened for depression using the 9-item screening tool known as the Patient Health Questionnaire, or the PHQ-9. And this tool is well validated in primary care settings in order to screen, diagnose, measure, and monitor depression severity. So it includes the 9 diagnostic criteria for making a DSM-5 depression diagnosis. And you can see here the response option follow as not at all, several days, more than half the days, and nearly every day. And the scoring is pretty simple, so just 0, 1, 2, or 3 points based on the individual's response. So item 9 of the PHQ-9 does ask about suicidal ideation. So in the past 2 weeks, have you been bothered by thoughts that you would be better off dead or hurting yourself in some way? And as part of clinical recommendations, if a client responds anything other than not at all, including if they refuse to provide a response, then that client should have a further risk assessment to determine whether they might be at imminent risk of suicide. So just in general, most risk assessments do contain these 4 core principles. So the first is desire, so the frequency and the intensity of these thoughts of suicide. Capability, whether the individual's behavior indicates that they're capable of suicide, whether they've had a previous attempt, things like that. Next is intent, so whether the individual has expressed an intent to die by suicide, whether they have a plan or the means to sort of act on that plan, and other sorts of preparatory behavior. And then finally, buffers. So whether they have any sort of immediate supports like family, friends, crisis services, things that might mitigate that risk of suicide. And this can also include meaningful components of their life. So having a job, pets, religious beliefs, things like that. And then based on those 4 core principles, risk can often be categorized as either mild, moderate, or high or imminent risk. So, of course, if you're a practitioner and you're enrolling clients in the STOP program or any sort of program and you're screening for depression, if someone does indicate suicide, you'll often just follow your organization's policies on conducting a risk assessment or help that client develop a safety plan. However, as part of the mood management initiative, within the STOP Family Health team, we were also interested in assessing any changes in PHQ-9 score at 6-month follow-up. And so as part of our STOP program's workflow, these clients could complete a 6-month follow-up survey in one of 3 ways. So the first is in office with their healthcare provider during like follow-up visit, or they could complete it by themselves through email. So on the 6-month anniversary date of enrolling in the STOP program, they would receive a link to complete the survey by email. And then finally, they can also complete the survey over the phone with one of our non-clinical research analysts. So that sort of brings us to the question of, well, if someone is completing this follow-up survey over the phone, how should our non-clinical research staff respond to clients who might be indicating suicidal ideation? And so that brings us to our third learning objective. And I should mention that although sort of the reasoning for us creating this protocol was based on our STOP program's workflow, these sorts of protocols are important to consider and are relevant for really any research study where, you might be screening for depression, but you're relying on the use of non-clinical research staff, or you're in a situation where you have maybe front desk personnel who might be in situations where there might be clients endorsing suicidal ideation, and you need some guidelines on how to respond to that. So just sort of briefly going through how we developed and implemented our protocol, we first started by reviewing the current literature. So this involved looking at research studies and clinical guidelines for conducting risk assessments, as well as exploring what other research studies at CAMH were doing in terms of their protocols for supporting non-clinical research staff who might be encountering clients with suicidal ideation. And what we found was that there wasn't really a whole lot specifically pertaining to smoking cessation, but in general, what protocols had recommended was sort of two things. So first, enlisting information for detecting risk factors for suicide, and then sort of triaging those potentially at-risk research participants to the appropriate level of care. And so from there, what we did is we sort of created like a concept map of all the key features of risk assessments, which included those 4 core principles that I had mentioned. So desire, capability, intent, buffers, and then some questions that we felt might be important to ask in order to assess those 4 core principles. And I should mention that when creating these sorts of protocols, it's also important to really consider your own organization's context and then adapt the protocols accordingly. So for us, one of the major features of developing our protocol was this collaboration piece with all the different components of the nicotine dependent service. So collaborating with our research analysts who would potentially be implementing this protocol, collaborating with our research coordinators, our principal investigator and other co-investigators, as well as clinicians, so that they could help inform the protocol based on their own expertise and perspectives. The other major consideration that we had was the fact that these surveys could be completed, again, over email or over the phone. So really thinking of how we would kind of implement a risk assessment protocol if someone indicated suicidal ideation through one of these sort of remote contacts. And so when creating this, again, it was definitely an iterative process. So really going to the literature, collaborating, and really thinking of how we could implement this given STOP program's workflow. And sort of from this exercise, what we considered was that when clinicians are undergoing risk assessments, there's often this aspect of using your clinical judgment in order to determine whether someone is at imminent risk. However, when we're working with non-clinical research staff, we really wanted to make it as specific and objective as possible in terms of, okay, what would really warrant someone to be at imminent risk. And so after kind of gathering all that information, we consolidated it, and then we sort of distilled it down into, again, what is the most important component of a risk assessment? What would sort of the immediate things to look for to determine if someone was at imminent risk? And for us, we determined that that would be whether someone had a plan and or the intent to act on that plan. So very briefly here, I'm just going to sort of go over our risk assessment protocol. And what I'm presenting here does pertain to research analysts who are speaking over the phone with a client. So from the top, if a research analyst is screening for depression using the PHQ-9 and someone responds anything other than not at all to that 9th item, so a score of 1 or more, or if a client refuses to respond to the question, then as part of our protocol, that the RA would be directed to conduct a brief risk assessment in order to determine if the client was at imminent risk. And so they might begin by saying something like, like in your responses, you indicated thoughts that you would be better off dead or hurting yourself in some way. I am concerned about you. Do you mind if I ask you just a few more questions? And from there, they would proceed to ask them, have you made a plan for how you might do that? And this goes back to that very objective measure of imminent risk that we discussed, so whether the client has a plan. If they say yes, then the RA would be directed to contact one of our CAMH clinicians in order for them to do a further risk assessment to determine if the client really is at imminent risk. And so one thing to consider here is, again, that these risk assessments are taking place over the phone. So apart from just sort of gathering, trying to contact the CAMH clinician, they also have to make sure that the client remains on the phone. So we do have some tips in our protocol for how the RAs can contact the clinician, which I'll discuss in a minute. But in terms of sort of making sure that the client remains on the phone, we've suggested that our RAs sort of ask some additional questions in order to elicit more information, which they can then hand off to the clinician. So first, they might ask questions about the client's location. So for your safety, may I know where you're located? And this is important because, one, if the call gets dropped, then we know where they are. Or in more serious cases, if the client hangs up and we do need to contact 911, again, then we know where the client is located. Next, they might ask questions like, have you started making preparations to carry out your plan? Have you thought about when you might carry out this plan? And other questions that sort of get at that preparatory behavior. So then once the clinician arrives, they will take over the call and then just do a more thorough risk assessment to understand the client's intent and whether they have any supports available, things like that. And regardless of the outcome of the call, it's always important to kind of loop in the client's circle of care so that they're aware of the situation and they can also provide some additional support if necessary. And so for us at the STOP program, that would include the healthcare provider at the family health team where the client enrolled in the STOP program. And this is usually the person that actually enrolled the client in the first place. And then, of course, it's also always important to document all of this information in the client's electronic medical records. So for us, this is a STOP portal, and then we also save this information on a secure data folder on our CAMH server. So that's sort of the protocol if a client was deemed to be at imminent risk. If a client is not at imminent risk of suicide, so, they responded anything other than not at all to that 9th item, however, they don't indicate having a plan, then the RA is encouraged to let the client know that, if anything changes, we encourage you to call 911 or your local distress center or report to your nearest emergency department if it's an emergency, and also involve a support person, so a family member, a friend, something like that. And as part of our protocol, we've also kind of created this list of all the family health teams participating in STOP, as well as their associated distress and crisis centers. And so all research analysts are given a copy of this list, and we suggest that they sort of hang it on their bulletin board or keep it on their desktop so that if they are in this situation, they can very easily pull it up and look at what family health team the client is calling from and then provide them with the appropriate distress or crisis line. And then, of course, again, it's important to always document the call outcome, both on the client's record on the STOP portal, as well as in a secure data folder on our CAMH server. And so, like I mentioned, when creating these sorts of risk assessment protocols for non-clinical staff, it's also always important to adapt it to your own organization's context. So for us, again, because our clients could complete this follow-up survey either over email or over the phone with our RAs, there were some features that we implemented based on that workflow. And then sort of again in March when in response to sort of those first stages of the COVID-19 pandemic where a lot of our work sort of became even more remote and worked from home, we did implement some additional steps just to sort of adapt to those changes. So I've listed some of them here just in case they are helpful for others. But just in general, regardless, again, of whether it's remote or not, it's always important to provide trainings and ongoing supervision to non-clinical staff in order to support them with implementation. And I believe Rosa is going to get to that in a second. But then the other things that are important to do is, so we also provided our research analysts with our clinician schedule so that every day they knew before they made a call who was the clinician on duty and who they needed to contact if there was an imminent risk case. We also suggest, so before, kind of prior to COVID, when things were in office, if a client was deemed to be at imminent risk, the RA could basically kind of just stand up, flag one of their colleagues and let us know, like, hey, I need you to get a clinician. Or in most cases, our RAs also have sort of wireless headsets, so they could actually get up and go to the clinician's office themselves and sort of hand over the call that way. Now that we're working in more of this work from home environment and many of our research analysts are working from home, what we suggested they do is before they make a call, they have a pre-drafted email or text message that sort of just says something like, heads up, there's an imminent risk call coming your way, so that if they're on a call and they sense that, this might need some escalation, they can very quickly just send that off to the clinician on duty. And then if the client is at imminent risk, what we've implemented is just some basic three-way calling. So the RA would call the clinician and then merge the call with the client, the RA and the clinician, and then put themselves on mute so that then the clinician and the client could discuss. And then, of course, again, as I mentioned, some of these surveys also take place through email. So in those cases, if a client indicates suicidal ideation through email, what we've actually developed is sort of like a daily report. So every morning at 8 a.m., all of our research analysts will receive sort of a list of all the clients who indicated a score of 1 or more or didn't respond to item 9 of the PHQ-9. And then the RAs would have 24 to 48 hours to call the clients back in order to then follow up and do that brief risk assessment. And then in terms of communication with Circle of Care, we've also drafted a number of different phone and email templates for our research analysts and for our clinicians in case they need to get in touch with one of the self-health care providers or they need to email the client in order to follow up. And if anyone's interested in getting a copy of those templates, if you think that it might help you, then we are more than happy to share that with you. And so now we thought it'd be nice to just sort of share a brief overview of some of the results that we found since implementing this protocol back in August 2018, which was when the first set of 6-month follow-up surveys went out and the PHQ-9 was added to them. And this data is up until March 17th, which was sort of the first state of emergency lockdown due to the COVID-19 pandemic. So since then, about 20,710 participants completed a 6-month follow-up survey. When we look at follow-ups completed over the phone, about 18% of participants did score 1 or more on item 9 of the PHQ-9, which included about 2% of participants who responded, don't know, prefer not to answer. And when those clients were followed up with through the risk assessment protocol, 4 of them were deemed to be at imminent risk of suicide. And then when looking at follow-ups completed by email, about 16% of participants scored 1 or more on item 9 of PHQ-9, which included about 38.5% who responded, don't know, prefer not to answer. And so in these cases, the RA would then get that email and would be responsible for following up with these clients. And 67% were successfully contacted in order to conduct the brief risk assessment. And then from those participants, 2 of them were deemed to be at imminent risk of suicide. So that was just sort of a brief overview of how we developed and implemented our protocol and some of the results that we've had since implementation. Now I'm going to hand it over to Rosa, who's going to just discuss some of the general themes and findings since implementing this protocol.
Thank you, Shelly. So there's so much that I can talk about in terms of what we learned from here. So these are just some of the highlights. And I've been looking at the questions, and so hopefully I can weave some of those answers in, but we're going to go through the questions as well. So as you can imagine, when we first talked about, implementing this protocol or even just about implementing the PHQ-9, in some of the STOP implementation, there was quite a bit of anxiety, some initial fears, because people weren't sure what to expect, right? They're not trained as clinicians. Suicide is a topic that makes a lot of people uncomfortable, including healthcare providers. None of us really love to deal with this kind of stuff. It makes us anxious, of course, just because of the nature of the situation. So you can imagine, a research analyst who doesn't have any training in this type of intervention, there was a lot of fear and anxiety. So to help with that, Shelly talked about, including the staff in the development of the protocol, so it helps to give them a little bit of control, helps them flag some of the issues that they anticipate they might face. So that was actually a really helpful process because, so my background is I am a clinician, and so, I might take a lot of things for granted. I've been trained in screening for suicide. I generally know how to respond. And so having people who have not had that kind of training involved in the protocol development was really helpful because they did highlight things that we had initially not thought about. And the protocol, we haven't shared the full protocol today. Shelley, I don't know if you know exactly how many pages it is, but it is pretty detailed. So again, we made sure to provide as much information for the RAs to guide them. And we can definitely share the protocol if people are interested. But it also has a lot of appendices. So one-pagers, checklists, things that people can post on their desks as they're making follow-up calls so that it's there in front of them as a reminder. So those are some things that really, really helped. In addition, so I've been doing supervision with the RAs from like the very beginning of STOP. We meet on a regular basis just to talk about, what they're experiencing when they're making follow-up calls. At CAMH, they're actually seeing clients in person. And so we talk a lot about communication skills. So our RAs have received, basic motivational interviewing training so that they know how to engage clients and just general communication skills. We talk about setting boundaries. We actually talked about screening for suicide or responding to people who indicate thoughts of suicide even before this whole project came to be, because whether you're screening for it or not, clients may actually share some of that with you. So something to consider that, people should be trained or have some kind of mentoring or supervision around this topic because clients will share that with you. So supervision continues to happen, and we touch base about the protocol and how things are going on a regular basis. And the training is also ongoing. There was an initial pretty intensive training with all of the RA staff that Shelley and I both led. And that really helped to, I think, alleviate some of the fears that the RAs had. But we continue to have just-in-time training. So as things come up, we'll talk about it in supervision, and then we can provide the additional training that's required. So the protocol development is not actually done. It continues to evolve. Of course, March rolled around, and all of a sudden we had to as all of you had to, we had to look at, okay, how do we do this work now that everybody's working from home and they don't have that in-person support? Because what would often happen is if an RA had a call, they did an initial screening, and they thought, yes, this needs to be escalated. They'd literally walk over to my office and say, I've got a client on the phone, and I would take over. So, the protocol is never going to be done. There will be challenges along the way and things that we learn along the way. So again, it continues to grow, which is a good thing. So just to kind of, touch a little bit about what some of the fears were among the RAs. One was, what if I say the wrong thing? What if, a client tells me that, they're thinking about hurting themselves and I say something and it makes it worse? So again, one of the things that we did was talk about, communication skills and training. Generally, things that you can say that indicate to the client that they're actually being heard, that, there's often, I heard a number of times from several staff that, if we talk about this, we're going to put these ideas into their head. And that's actually not true. It's already there. And it's better that we acknowledge that, hey, I hear what you're saying. I can hear that you have some concerns, that you're worried about hurting yourself, and we're going to get you some support. So that was one of the fears. I think another one was the client is going to get really angry if we then tell their provider at the family health team or their primary care provider that this happened and that we did an intervention. They're going to get really upset. So again, it's really about helping the client understand that this is a circle of care and that we are not just here to collect data about their smoking. as most of you know, I see a lot of self-implementers on the call. Our program is meant to be comprehensive. We don't want to treat tobacco cessation in isolation of everything else that's going on, because as Shelley talked about at the very beginning of the webinar, there is an association between suicidality, suicidal thoughts, and smoking cessation. So it is something for us to consider, and explaining to the client, why are we asking these questions in the first place? Helping them understand that, we are trying to provide them comprehensive care, and that we can actually help support them, and that we're not communicating to the fit because, we're telling on them. We're communicating to the fit because we want to ensure there's continuity of care, that when they go back to their primary care provider, they get the continued support that they need. And I Shelley, I don't know if you're aware, but I know that I think there was maybe one client that really was a little bit upset about this, but other than that, we really have not had any major complaints.
Yeah, we usually, clients are actually grateful that we are sort of taking this additional step, especially during times like now where, you may not always get that social interaction that you used to. We've had feedback that, some clients are actually really happy that we are asking these questions. And like Rosa mentioned, maybe one or two clients who were upset by, they felt it was a little intrusive, but other than that, it's been a pretty good uptake.
Yeah, thanks for that, Shelley. And so one of the things that I noticed, as I said, at the very beginning, there was a lot of apprehension among the RAs, lots of anxiety. Some even just said, I don't want to do this. It's too difficult. This is not what I signed up for. But again, involving them in the protocol development, providing the ongoing training, the initial training plus the ongoing training, the supervision, what I've noticed is actually a huge shift among all of them. Are they still anxious about it? Probably, but I would say most people are when you're doing this type of work. Again, suicide, having a client who's expressing suicidal thoughts is anxiety provoking, and that's okay. But we still have to deal with it. But the shift that I've noticed is that, when we have a new RA join and we, review the training with them, it's the other RAs that are now jumping in and saying, yeah, this is how you can do that. This is what I do when I hear this. And it's just been an amazing growth to see among the staff. I actually get to sit back now and just kind of watch them, support each other. And that's the other thing is, and again, this was more when we were all on site and, because they all sit together, there was a lot of peer support as well. So when they heard, somebody on a call, they're struggling, somebody's, expressing suicidality, they support each other as well. But again, always important to have a trained clinician ready to provide the additional support and then to do a full risk assessment. I'm going to just stop because I think there's probably some questions that I've actually also copied them down. So I'm just going to go and start here. Yeah. So is it a good idea to encourage someone with bipolar disorder to stop smoking during a pandemic? So one of the things that, this is anecdotal, we'll look at the data at some point, but what I get the alerts every single day to see, has anyone actually screened 1 or higher or missed the question 9 on the PHQ-9? And what I did notice was there was a little bit of a blip at the beginning of the pandemic. I did see an increase. There were actually some days there were like 3 clients expressing that. I have noticed that it's subsided now. Like there are several days that go by and nothing gets flagged. Those are email screenings, of course. We will look at the data to see what's actually happened. Now, having said that, somebody with bipolar disorder who does have a higher risk of having suicidal thoughts and even attempts. So the answer is, should they be advised to quit smoking? I mean, there are still higher risks of continuing to smoke Not all clients who quit smoking will, express suicidal thoughts. The prevalence is still quite low, which is a good thing. I would say that if you do have a client with bipolar disorder or any other mood disorder, it's providing the appropriate support and monitoring. Ask those questions, do the risk assessments, check in with them often, let them know that, as they quit smoking, their mood can be impacted both positively or negatively. And so we're going to monitor that. This is why I'm going to ask you these questions, and feel free to use the PHQ-9 or other tools that screen for some of these issues, and then provide the appropriate support. So yes, I think it's still important that, and still okay to encourage people to quit smoking, whether they have bipolar disorder or any other mood disorder. But it is really about providing the monitoring, screening, and the appropriate support. There was, going back to, because I think somebody asked about, Claire, I think you made a comment about you find that clients are more affected now with ideas of suicide prior to the shutdown. They're having greater difficulty either being smoke-free or wanting to start the quit process, and that, your counseling has changed. So it's funny because I literally last week I just listened to Quick Takes, which is a CAMH podcast on suicidality. And again, this wasn't necessarily supported by data, but the psychiatrist who actually, this is her specialty, talked about, we make this assumption that suicidality can go up, and I'll talk about the data in a second, but there's also, we also need to look at some of the positives that have come out of, actually I wouldn't say positive, sorry, but one of the things that she talked about was that, we're all going through this together, and that's the message you hear. You hear it on TV, CAMH has it, we're in this together. And there is something about that actually has helped to support people in a way. So something to keep in mind. But there was a study done by the Canadian Mental Health Association. And because, of course, the intense stress and disruption that the pandemic has caused, they have found an increase in suicidal thoughts among certain subgroups of the population. So in particular, people who continue to face, disparities in treatment and care. So people with, for example, mental health issues. We've seen a little bit of an increase in that population. Indigenous populations, those with a disability, those from LGBTQ+, but as well as parents. Parents, of course, of younger children. So I think they found an increase. So in 2019, 2.5% of Canadians reported having suicidal thoughts, but this year that has gone up to 6%. So yeah, there has been an increase. And again, it's, definitely within subgroups of the population, something to pay attention to. So, but on top of, suicidality or suicidal thoughts, they also found that parents who have kids under the age of 18, there's other stressors. So, feeling anxious and worried, that prevalence has gone up. People reporting a mental health, decline in their mental health. Alcohol use has actually increased from 17% to 29%. People being worried about being safe, or physical, emotional, domestic violence has also gone up. So it's not just suicidality. On the flip side, the study also talked about some signs of resilience. So parents, while they're struggling, did report that, increased quality time. They also, quality time with their families, increased resilience that they observed in their own children. A lot of parents initially were worried about the impact that it would have on their kids, and many are finding that actually kids are coping quite well. And then, people increasing their exercise and physical activity during this time. So those are some important things to consider as well. Let's see, there was another question that I wanted to get to. Yes, so what suicide training intervention does a healthcare provider have at the FIT? I don't know if your FIT actually provides any training, but I think Claire also put a link. I just want to make sure. I think the Canadian Mental Health Association does provide its assist training that you might want to look into. So that's an important one. And we actually have two of our teach faculty who do this training as well, Carolyn Platter and Stephanie. They also do that. We can provide some of those resources for you as well. Yeah, and I think, were there other questions? I think that was it for questions. Yes, the assist training is really great. I definitely recommend it for all healthcare providers, for sure. Shelley, do you want to go to the next slide, or?
Yeah.
So, yeah, so one of the things, I'll let you take this on in a second. So, you know, we spoke a little bit about the protocol. It's very detailed. And one of the things that we did was, you know, Shelley actually compiled a list of the different resources that we could provide to clients so that our research staff had something to offer clients, not just, you know, go talk to your healthcare provider. You know, we provided them with the crisis lines. We provided them with self-help materials and other different types of support. So again, you know, that also helps with the RAs feeling less anxious and less helpless, because you can feel helpless when somebody is feeling like they want to hurt themselves, and this gives them an opportunity to offer something to the client. So I think, again, in the year and a bit that we've been doing this, I've had to take over maybe about 5 calls, maybe a few more. And most of the clients, it really is the theme that I've noticed, anyway, among our clients that participate in STOP, is this theme of isolation and loneliness. That's one. The second one is pain that they're experiencing. So those are the ones that we flagged, right? So pain is a big issue. I'm sure most of you are dealing with this as well. People are in physical pain, but also emotional pain. And really it comes down to, you know, people, do they want to hurt themselves? Do they really want to die? No, they want their pain to end. And so if we start talking about, you know, how to get some support around pain management, that already helps. And so, and again, I think a lot of you probably already know this because you're doing the frontline work on this issue. But the other one is the isolation. And so just by us asking that question, talking to them a little bit, providing that support makes a huge difference. And that's what I've heard from clients directly saying, you know, thank you for allowing me to share this. Thank you for talking to me about this. I feel better already. And so, you know, again, one thing to always remember is that, you know, we don't make things worse by asking about suicide. We actually make it better because, one, we tell them, yes, we are interested. We want to hear what you're going through. We're interested in helping you. We're here to support you, and that makes a huge difference. So Shelley, do you want to just talk a little bit about the resources?
Yeah, so two of the main ones that I just wanted to highlight was this new app created by CAMH, which is called the HOPE app. It's available for iOS and Android, and it's essentially just a client-facing app where it can kind of support your clients with developing a personalized suicide safety plan, and it can be completed with a healthcare provider, as well as some resources there if someone does need sort of support with this. And then the second is one that I'm sure some of you may have seen on the STOP program, on the STOP portal, which is our Self-Awareness Managing Your Mood Workbook. Again, available on the STOP portal as well as our NDS website. And again, just provides a number of different tools and information and resources for smokers who are looking to quit smoking, but also maybe need some support with managing their mood. And then, of course, some other resources include our CAMH crisis resources and local distress center numbers. And I think that wraps it up for our presentation. If there's any more questions, feel free to put them in the chat or send us an email afterwards. I did have a number of people asking for the actual risk assessment protocol, so we'll make sure that we send that out with Sophie's email with the post-learning assessment. And yeah, I'll hand it off to Sophie now. Thanks.
Perfect. Thank you both for such an informative webinar. That was excellent. Just a quick reminder that a link to the evaluation and post-learning assessment will be sent by email by the end of day tomorrow, and you'll have 1 week to complete that if you would like a letter of completion. As well, in that email, we'll send those resources and a copy of the slides along. As well as if you participated as a group today, please email teach@camh.ca with a list of the names who attended by 2 p.m. today. If you missed a portion of today's webinar, or if you're interested in viewing it again, we will be posting a recording of this webinar to our YouTube channel as well as on our website. Thank you so much, everyone, and have a great rest of your week.
Bye, everyone.
Thank you, everyone. Bye.
Stay safe.